Hello, welcome back to Pharma Training Solutions. I welcome you back. In case you haven't subscribed, you can click on that subscribe button at the end and like the video at the end. Of course, I'll explain all this one later on. Today I'll be talking about the anti-diabetic medications or the anti-diabetic pharmacology. Now, what is DM? Of course, DM is a condition which is characterized by an elevated blood glucose levels, of course, due to impairment of insulin sensitivity or inadequate insulin secretion. Now, insulin is produced, we know, by the beta cells of the islets of Langerhans. Now, the types of DM, we have type 1, insulin-dependent, type 2, non-insulin dependent, and we have the gestational DM. Ensure you can differentiate between these two DM. We may talk about them later on in our presentation, where we shall be discussing the therapeutics. We shall explain the pathophysiology of DM, shall explain them better. Now, we also have gestational DM. This one is common in pregnancy, first-time pregnancy, and the types which are due to other conditions. I'm sure you are aware of them. Now, let us first talk about insulin release, because we have to know insulin release if you have to know the mechanism of action of all these other drugs, because they affect insulin release. Of course, high blood glucose levels, which transported by the GLUT4, results in an elevated ATP, which inhibits or closes the ATP-sensitive potassium channel. Because most of them shall be saying they activate these channels, leading to cell membrane depolarization. Hence, this leads to opening of the voltage calcium channels. Now, and an increase in intracellular calcium. Now, of course, this increase in intracellular calcium results in exocytotic release of insulin from the stored vesicles. Remember, I didn't talk about how insulin is produced, because you have now insulin is produced. Because when this calcium enter the vesicle, they cause the vesicles to move towards the membrane, and hence release of insulin. Because the mechanism of action of most of these drugs shall be just saying they activate the ATP, inhibit this, as simple as that. But you should know this one very well. You can refer to it. Let us look at the ADM drug. Of course, we have the insulin, the release hormone. We also have the oral one, mostly is in type 2. The secretagogues have sulfonylureas and Meglitinides. Have the Biguanides, the thiazolidinones, and the alpha-glucosidase inhibitors. We have even others which I didn't talk about, as these are the common ones which we find in pharmacies. Now, let's look at the effects of insulin. Of course, which are those effects of insulin? It promotes glucose storage, of course, by inhibiting glycogen synthesis. It increases triglyceride synthesis. It inhibits gluconeogenesis, conversion of amino acid to glucose, and it increases the rate of transport of amino acid into tissues, decreases the rate of protein degradation. Now, all these ones are leading towards decrease in blood glucose levels and other effects. Now, let us classify insulin, because it's important to know the insulin. Which are just classification of insulin we have. We have rapid action insulins. These ones have a rapid onset of action, at least 5 to 15 minutes. The peak is within 1 to 3 hours, and they have duration of action of about 5 to 4 to 5 hours. Examples of insulin Rispro, insulin Aspart. We also have the short acting. These ones effects are within 30 to 60 minutes, and the duration of action is between 5 to 8 hours. Examples, we have zinc insulin and the soluble insulin. We have intermediate acting insulin. These ones have at least a longer rapid effect, which are between 2 to 5 hours, and the duration of action is between 4 and 12 hours. Isophate insulin and the NPH. Now, ensure at least you are aware of the onset, the peak, and the duration of action of each classification. We have the long-acting insulin. We have this one, of course, or the action are between 1 to 2 hours. The peak is between 4 to 6 hours, and the duration of action is more than 12 hours. We have insulin glargine and insulin ditmer. Ensure you know the examples, the description, and the class. Now, we have the mixture, or the mixture, which are in combination. We just call it combination, not mixtures. Combination. Because we have the mixture, which has NPH and aspartate. It has NPH and the aspartate. Yes, these ones. Well, of course, we have even other mixtures, which I will talked about. 30 of NPH and 30 and the other one, 7 of NPH and 30 of this one. Now, how is it given? It is given by subcutaneous, of course, using insulin syringes, portable pens, or you can use an insulin pump. Now, ensure you know how to calculate the IU to give, the international units. In case you don't know how to calculate them, we can help you. Side effects of hypoglycemia, hypertrophy after injection site. Sometimes you have local pain, but the common one is hypoglycemia. Now let's look at the sulfonylureas or the secretagogues. They as insulin secretagogues and increase insulin release from the pancreas through closure of the potassium channels via the potassium ATP channel modulator. Are you getting it? This one. Remember I talked about how insulin is released above. Now here we're just saying that they increase insulin release via closure of potassium channels. It is enough because already above you know how insulin is released, and also can reduce serum glucagon levels. Now they are classified as first generation, where we have tolbutamide, tozolamide, chlorpromide, which are rarely used today. But the common ones which are used today are the second generation. Have the glibenclamide or the glyburide, the glipizide, and the glimepiride, which may be available in combination or as single drugs. Even double strength. I'm sure in terms of double strength, mostly in combination with other drugs. Now, use in type 2 DM in combination with metformin. So side effects, we have hypoglycemia and weight gain. Let's talk about the meglitinides. These are also insulin secretagogues, which increase insulin release from the pancreas by closure of the potassium ATP channel, but at a different site from the sulfonylureas, at a different site. Examples, we have repaglinide and nateglinide. These are the examples. Let's look at the Biguanides or the metformin. Now, this one has several mechanisms of action: reduced hepatic glucose production, stimulation of hepatic fatty acid oxidation. It also increases glucose uptake. Now, sometimes they say it increases glucose sensitivity. Yes, maybe because the mechanism of actions are many. It is given orally, and it is the first line treatment of type 2 DM as monotherapy or in combination with secretagogues. Now, the side effects have GIT distress. Now, never talk about nausea and vomiting. Always say the GIT distress and others, because all of them are GIT distress. If I someone that asked him side effects of a drug, nausea and vomiting, nausea and vomiting, nausea and vomiting, nausea and vomiting, diarrhea, nausea and vomiting, diarrhea. Because all drugs will do that. No, be scientific. You have to say GIT distress or GIT discomfort. Let's look at the thiazolidinines. They decrease insulin resistance, leading to increased tissue sensitivity to insulin. Examples of the pioglitazones, rosiglitazone, all are given orally. We also have the alpha-glucosidase inhibitor, this enzyme. Examples of acarbose and meglitol act by reversibly inhibiting membrane-bound alpha-glucosidase enzyme. Now, of course, this enzyme is required in absorption of carbohydrates. When you inhibit them, when you inhibit the enzyme, of course, no carbohydrate will be absorbed, and hence there will be reduced blood glucose levels. Examples, side effects we have, examples I said we have acarbose and meglitol. But the common is acarbose. Side effects are flatulence, abdominal cramping, and this one, of course, these are all GIT distress. There are also other agents which are used. We also have hypoglycemic drugs which are used in hypoglycemia. Of course, the common one is glucagon. It increases hepatic gluconeogenesis. This is, of course, the opposite of what? Of insulin. It can be used in treat severe hypoglycemia in diabetics. It also is given intra IM or IV. Now, of course, we have these other ones which are used. The large volume drugs. We have dextrose 50% or 20%, depending on the prescription. This has been a short presentation on DM. We have others in endocrine. These ones in endocrine. Always refer to it later on, or refer to the standard books or the apps you have on your phone to understand more of these drugs. Always remain Wilson from M Pharma Training Solutions. Subscribe to the channel, click 7, subscribe, leave a comment on how we can improve, contact us, so always reply. And thank you very much.